So I'll get started because there's quite a bit of slides to get through. I don't have any conflicts or disclosures. And the two major learning objectives today are going to be to review the epidemiology, pathophysiology, and prognosis of atrial fibrillation and heart failure, and then go through the prevention of atrial fib with guideline-directed medical therapy and impact of atrial fibrillation on the efficacy of the GDMT we use. So we'll start off with some epi and prognosis of AFib and heart failure, move through the pathophysiology, and then we'll look at prevention of AFib with GDMT and impact of AFib on efficacy of the GDMT with all the different pillars of therapies we use in practice. And then I'll touch on the role of rhythm control as a new form of GDMT and go through any questions at the end. So my grand rounds are going to be based on the JACC state-of-the-art review that was recently published looking at this topic. And we'll start off with the epidemiology and prognosis. So the prevalence of atrial fibrillation is actually increasing worldwide due to increased life expectancy and improved survival from other CV conditions. In the USA, it's forecast to be close to 12.1 million people by 2030. And in Europe, atrial fibrillation among patients older than 55 years old are expected to increase to close to 18 million by 2060. Atrial fibrillation, we know, accounts for up to 30% of all ischemic strokes and is associated with depression, vascular dementia, increased mortality, and impaired quality of life. Heart failure prevalence in the USA and Europe is also on the rise. And although implementation of GDMT is associated with a 25% reduction in all-cause death at 24 months in our heart failure with reduced EF population, morbidity and mortality still remain high. And this is because GDMT is often delayed and many patients do not receive appropriate target doses. AF and heart failure coexist in up to 50% of patients. So both conditions have mutual risk factors and interactions. The Framingham Heart Study looked at participants that developed new onset atrial fibrillation or heart failure, and they found that 32% of patients diagnosed with heart failure had a previous history of atrial fibrillation, and additionally, 30% more were diagnosed with atrial fib after their initial heart failure diagnosis. And in contrast, among patients with new onset AFib, 8% had a previous diagnosis of heart failure, and then an additional 28% later on went on to develop heart failure. So a diagnosis of atrial fibrillation among patients with heart failure has been associated with worsening outcomes. So what are the risk factors for AFib and heart failure? There are several: age, coronary artery disease, peripheral artery disease, smoking, physical inactivity, obesity, kidney disease, hypertension, obstructive and central sleep apnea, diabetes, metabolic syndrome are all prevalent in patients with heart failure. But the most important modifiable risk factor is hypertension and accounts for the greatest population attributable risk for AF and heart failure. And in patients with heart failure, atrial fibrillation appears to be more prevalent in our heart failure with preserved ejection fraction population. The Swedish Heart Failure Registry showed that AFib prevalence increased sequentially among patients ranging from reduced ejection fraction all the way to preserved. So for example, the reduced ejection fraction had a prevalence of 53% compared to 65% in preserved ejection fraction patients. The Framingham Heart Study also looked at this topic and found again that AFib was more prevalent in heart failure with preserved EF compared to reduced. So what is the pathophysiology of atrial fibrillation in patients with heart failure? It is complex with multiple arms that we'll go through. So heart failure leads to elevated left atrial pressure, which then leads to increased endothelin 1 secretion. This then causes downstream atrial fibrosis and scarring, slowed conduction velocity, short action potential durations, and effective refractory periods. And this promotes re-entry in atrial fib perpetuation. There's also alteration in the pulmonary vein myocyte firing, which can promote and propagate atrial fibrillation. AF can also cause MR and TR due to annular enlargement, leading to elevated filling pressures and resultant fibrosis. Moving to the left side of the diagram, we know that our heart failure patients often have elevated sympathetic activity and RAS activation, which leads to uptitration of angiotensin II. And this then causes adverse atrial remodeling through profibrotic pathways, releasing pro-inflammatory cytokines, changing the electrical properties of the atrial myocytes, and this then predisposes patients to developing atrial fibrillation. And then finally, in atrial myocytes of patients with heart failure, we have a decreased expression of atrial L-type calcium channels, which reduce calcium entry into cells with myocyte depolarization, and this results in less calcium-induced calcium release from the sarcoplasmic reticulum. And finally, this culminates in increased frequencies of delayed after depolarizations and increased susceptibility to arrhythmias. Heart failure can result directly from atrial fibrillation in tachycardia-induced cardiomyopathy. Of course, this involves complex pathophysiology involving remodeling of the electrical system, abnormalities in calcium homeostasis, and downstream sequelae which result in LV dysfunction. Tachy-induced cardiomyopathy is the most common cause of heart failure in atrial fibrillation patients. But there are other mechanisms as well. So in patients with atrial fibrillation, we often see left ventricular filling, which is impaired due to loss of effective atrial contractility and shortened diastolic filling times. This is due to increased resting heart rates, irregular ventricular rhythms, and culminates into reduced cardiac output and elevated intracardiac pressures overall. There is also left atrial dilatation in our AFib patients, which can lead to atrial functional MR. And significant secondary MR is often associated with increased symptom burden and poor quality of life. And finally, AF-induced left atrial dilation and atrial and ventricular fibrosis can lead directly to heart failure with preserved ejection fraction. And this is why one of the theories this is the theory explaining why there's increased prevalence of atrial fib in preserved EF cohorts compared to reduced EF. So what are the prognostic implications of atrial fibrillation and heart failure? Well, AFib is associated with increased mortality, but there is heterogeneity of this based on the patient's ejection fraction. So we can see in this study by Sartipi et al. Published in JACC that our patients in the black lines here are in sinus rhythm, and they have a better cumulative survival compared to the atrial fibrillation patients depicted in red. And the AFib patients are then subdivided based on ejection fraction, and we can see that mid-range and reduced EFs are slightly better than our preserved ejection fraction cohorts. And although some studies show that HFpEF patients often have a worse prognosis when they develop atrial fibrillation, other studies have shown increased mortality across the spectrum of ejection fraction. Another analysis of about 12,000 patients by NCRD. Can we mute people?
Can everybody mute their phones, please?
Thank you. So an analysis of 12,000 patients by NCRD et al. In JACC also looked at this, and they found that patients with atrial fibrillation, those with heart failure and reduced ejection fraction, had higher rates of hospitalizations for HF and mortality compared to those with HFpEF. And we can see this in the bottom part of the graph here, are reduced ejection fractions on the left and preserved is on the right. And we can see the blue line here showing our hospitalization for heart failure and heart failure deaths is significantly increased. How does AF burden play an impact in the prognostic significance of our heart failure patients? So an analysis of 25,000 patients with heart failure who had some sort of device, a pacemaker, a defibrillator, was used, and essentially Wang et al. Found that there was an increasing AF burden associated with increased risk of heart failure, hospitalization, and mortality. So what they did is that they looked at people's devices and if they had subclinical atrial fibrillation. In those that had episodes lasting 6 minutes to less than 24 hours and did not progress to have longer duration SCAF, they had an annual rate of heart failure hospitalization of about 2.5% per year. But in those people who they found progression of SCAF to beyond 24 hours, there was a significant increase in the rate of heart failure hospitalization, close to 9% a year. And on the right-hand side in the gray box are the predictors of SCAF progression, including elevated BMI, older age, longer duration of the SCAF episodes. So moving on now to part two, looking at the prevention of atrial fibrillation with GDMT and how AFib can actually affect the efficacy of GDMT. So we'll start off with the ACE and ARBs. We know that heart failure patients have elevated sympathetic activity, activation of the RAS system, and this leads to uptitrated levels of angiotensin II, causing an increase in systemic vascular resistance, elevated aldosterone levels, sympathetic nerve release of noradrenaline, and myocyte fibrosis. And we know from many studies that ACEs and ARBs reduce morbidity and mortality in our HFrEF population and are recommended medications for those patients who are unable to take an ARNI. There's multiple mechanisms by which angiotensin II can also mediate atrial fibrillation. So angiotensin II can increase TGF beta 1, which can promote cardiac fibroblast proliferation. And some animal models suggest that the atria are more susceptible to TGF beta 1 induced fibrosis compared to ventricles. The increased vascular resistance, sympathetic activity, myocardial fibrosis that is induced by angiotensin II can also lead to elevated left atrial pressures, which then affects the atrial myocyte action potentials, shortens refractory periods, and then causes this increased susceptibility to AFib. And then finally, angiotensin II can directly affect the electrophysiology of the atrial myocytes. So there was a bit of an unclear benefit of preventing AFib among patients with hypertension, and some secondary analysis of heart failure trials provided evidence that ACE can actually prevent new onset AFib. So there was a single center study, the SOLVED trial, that took 374 patients without previous history of atrial fibrillation, and they gave them enalapril versus placebo. And we can see in the Kaplan-Meier curve in the enalapril on the top with placebo in the dotted line on the bottom. The enalapril group had more patients remaining free of the first occurrence of atrial fibrillation during a follow-up of almost 3 years. And these patients had a decreased LV function at baseline and were in sinus rhythm. Another study looked at trandalopril in patients with LV dysfunction following an MI, and they also found that patients in sinus rhythm at the time of the study entry had a reduced incident AF when they were placed on trandalopril. And a separate analysis of the SOLVED trial also showed that ACE inhibitors reduced clinically significant atrial fibrillation that resulted in hospitalizations and mortality. With respect to ARBs, there are similar findings. So the VALHEF trial, looking at almost 4,500 patients, found that the valsartan arm had 5% that developed atrial fibrillation compared to 8% on placebo. A composite analysis of CHARM, which looked at candesartan specifically, also showed that these patients were less likely to develop atrial fibrillation across the spectrum of ejection fraction. And the comparative effectiveness of ACE inhibitors on morbidity and mortality among patients with versus without atrial fibrillation was not reported in post-hoc analysis of the larger CTs, but an analysis of the CHARM trial showed that candesartan reduced cardiovascular death and hospitalization from heart failure, regardless whether or not patients had atrial fibrillation at the time of enrollment. Transitioning now to the ARNIs. So Angiotensin neprilysin inhibitors or sacubitril valsartan is a combination of an ARB and a neprilysin inhibitor. And neprilysin we know has many downstream effects, including degradation of bradykinin, natriuretic peptides, angiotensin 2, and adrenomedullin. And it counters the deleterious consequences from the sympathetic overactivation that is very characteristic in our heart failure patients. ARNIs are superior to ACEs in decreasing morbidity and mortality in HFrEF, and there has been some studies that show benefit in the preserved and mid-range EFs as well. So Solomon et al. Looked at ARNIs across the spectrum of ejection fractions in heart failure, and we can see in the graph that EF is on the x-axis here, and incidence rate of each of the outcomes is on the y-axis. And looking at primary composite outcome of heart failure hospitalizations, CV death, and all-cause mortality decreased markedly with increasing EF. And the rate of decline we can see is more impressive in our cardiovascular death and or heart failure hospitalization compared to the heart failure hospitalization alone. And all-cause mortality decreased from the lowest to the highest ejection fraction categories. Calcium mishandling is also a key contributor to the development of atrial fib, and there have been animal models showing that ARNIs enhance the function of ryanodine receptors, which can decrease calcium mishandling. And there was an interesting study by Lee et al. Who took mice, and basically what they did is they rapid atrially paced them to stimulate atrial fibrillation, and the mice were randomized to ARNI versus placebo for 3 weeks, and they found that the ARNI group had less atrial and ventricular remodeling and fibrosis. They had attenuated atrial electrical remodeling, longer atrial refractory periods, and less collagen and NT-proBNP that was secreted. Another meta-analysis by Liu et al. Looked at 6 studies of patients with heart failure, regardless of their ejection fraction, and they found that ARNIs did not lower the incidence of atrial fibrillation compared to an ACE or an ARB. An analysis of the Paragon heart failure trial, so our preserved EF patients. So the randomization of ARNIs did not result in less AFib among those without a previous history of atrial fibrillation at the time of enrollment. And then some smaller studies looking at ARNIs and reverse atrial remodeling also looked at the impact of AFib. And basically they took 64 patients and randomized them either to 160 milligrams of valsartan versus 200 milligrams of ARNI after catheter ablation for atrial fibrillation, and they found that the ARNI group had a decrease in atrial size, and this finding was not consistent in the valsartan group. So the evidence also shows that morbidity and mortality benefits of ARNIs among patients with HFrEF were not attenuated by the presence or absence of atrial fibrillation at the time of enrollment. Transitioning now to the beta blockers. So we know that certain beta blockers are favorable to reduce mortality, hospitalizations, and symptom burden in reduced EF populations. And specifically, those are carvedilol, metoprolol, succinate, and bisoprolol. And these benefits likely extend to patients with mid-range ejection fraction, as has been shown in some studies. However, evidence from studies enrolling patients with HFpEF, both with and without atrial fibrillation, suggests that beta blockers may in fact worsen symptoms in the HFpEF cohort. So from an atrial fib standpoint, beta blockers are first-line therapies for rate control due to their negative chronotropic effects, and this is achieved through many mechanisms. So they can prevent adverse remodeling and promote positive remodeling, which reduces left atrial pressure, a common trigger for AFib. They prevent atrial ischemia and fibrosis. There's excess sympathetic drive promoting atrial arrhythmias, and this is opposed by beta blockade. And then stimulation of beta adrenergic receptors often leads to shortening of our action potential duration, which triggers and maintains atrial fibrillation. And it is thought that beta blockers can reverse these changes. So the Capricorn trial that looked at carvedilol post infarct in LV dysfunction randomized patients to placebo versus carvedilol, and they showed a lower incidence of atrial fib or flutter post an acute MI. But it's not clear whether the mortality benefits of beta blockers in HFrEF are attenuated by the presence of atrial fibrillation at the time of enrollment. So there was a meta-analysis done by Rienstra et al. That included the Copernicus, Merida, HF, CIBIS seniors studies. It was almost 1,700 patients who all had a reduced ejection fraction under 40% in atrial fibrillation. And they did not find a reduction in the heart failure hospitalizations at the top panel or in mortality at the bottom panel among patients with atrial fib at the time of study entry. So this suggests that there is benefit of beta blockers that is limited to only in those patients with sinus rhythm. Another study also showing this by Kotek et al. Took 18,000 patients. It was a patient level meta-analysis of 10 randomized trials, and they found that beta blockade was associated with a significant reduction in mortality in HFrEF patients with sinus rhythm. So in panel A here is our sinus rhythm cohort, and we can see that the beta blocker group is significantly different from the placebo group compared to panel B, where it's our atrial fibrillation group, and there's no significant difference between the curves here. But again, there's conflicting evidence with the beta blockers. So there was a secondary analysis of the AFCHF trial by Kidron-Taruni et al. And basically here they took almost 1,500 patients with AFib and reduced ejection fraction. And those without beta blockers at baseline were propensity matched to a maximum of 2 exposed patients. And over a median follow-up of 37 months, they found that beta blockers were associated with significant lower all-cause mortality. And they did not find a significant interaction between beta blockers and the pattern or the burden of atrial fibrillation with respect to mortality or heart failure hospitalization. So panel A here basically shows the population overall, and then they did a sub-analysis in those patients that had a high atrial fibrillation burden, just to show that it doesn't matter how often or how long they are getting atrial fibrillation. So what's the reason for these divergent results? And what are the limitations of each study? So the trials included in each of the meta-analyses I mentioned had patients that were classified to atrial fibrillation versus sinus rhythm, but this was only based on a single ECG done at the time of the study enrollment. So it raises the possibility that some patients may have had paroxysmal AFib and may have been misclassified to the sinus rhythm group. Also interesting to note is that the prevalence of AFib was less than 20% at baseline in both of these meta-analyses, despite the registry studies suggesting that AFib is present in more than 50% of patients with heart failure. Each of the observational studies also had significant important limitations. So beta blockers exert different degrees of benefit among patients with reduced ejection fraction versus mid-range versus preserved. So that's one important distinction. The registry data did not include NYHA functional classes or actual doses of the beta blockers, which can also influence the outcomes. And then finally, that last study we talked about, the Kidron-Taruni et al. Study, the investigators' propensity matched patients that received beta blocker therapy to those that did not to determine whether beta blockers improved outcomes in AFib and heart failure with reduced ejection fraction. And before the propensity matching, the patients that received beta blockers were often younger, more likely to have non-ischemic etiology of their cardiomyopathies. They were on, most of them were on oral anticoagulation, and they had an ICD. And each of these factors has been associated with better outcomes. So obviously there is some confounding information and results here. Switching gears now to our mineralocorticoid receptor antagonists. So, as mentioned previously, we have high RAS activation. So, this leads to excess aldosterone in our heart failure patients. And aldosterone then binds to our MRA receptor, which can cause many downstream negative consequences, including salt and water retention, elevated blood pressure, activation of pro inflammatory and pro fibrotic pathways. ACE inhibitors have been shown to transiently reduce aldosterone levels, although after 1 year, there are studies that show that aldosterone is increased compared to baseline. And among patients with heart failure and reduced ejection fraction, we know that our MRAs can decrease heart failure hospitalizations and mortality. We're all aware of the TopCat trial that looked at MRAs in the preserved EF cohort, and they did not reduce the primary composite endpoints in that trial. However, there is this subgroup analysis that suggested the possible benefit when we evaluated only the North and South American populations. And the post hoc analysis suggested that patients on the lower spectrum of the ejection fraction tend to have more benefit. So atrial fibrillation is significantly increased in patients with hyperaldosteronism, and this led to a hypothesis of aldosterone being involved in the pathogenesis of AFib. So in 2012, Ray et al. Did a small study, and they used rats where they implanted these osmotic mini pumps that continuously delivered either aldosterone or a non-reactive control. After 8 weeks of the infusions, they burst pace to the rats, and 100% of those on the aldosterone infusion developed atrial fibrillation compared to only 2 out of 9 rats in the control group. When they did EP mapping, they found that the aldosterone mini pump group had prolonged P wave duration, prolonged total right atrial activation time, and local conduction times. When they looked at the histology, they found that there was more atrial fibroblasts and interstitial collagen in the aldosterone group. And this suggested overall that aldosterone can provide a substrate for atrial fibrillation by altering atrial conduction fibrosis without a significant impact from hemodynamic derangements. And several animal studies have also shown that MRIs can actually decrease this atrial fibrosis and incidence of atrial fibrillation. When looking at some of the human studies, so a secondary analysis of the Emphasis heart failure trial looked at patients with and without atrial fib at the time of the enrollment, and eplerenone was found to reduce the frequency of incident atrial fibrillation and composite endpoints of death from CV causes or heart failure hospitalizations for patients with reduced EF. A secondary analysis of the TopCat trial did not find a reduction in incident or recurrent EF in in patients with preserved EFs. And then a separate analysis of the TopCat trial that took that subset of patients from the North and South America found no difference in post-randomization incident atrial fibrillation between spironolactone and placebo. But in that sub-cohort group, they found that the benefits of spironolactone persisted regardless of whether the patients had AFib or not at baseline. The IMPRESS AF, so this one was the improved exercise tolerance in heart failure with preserved EF by spironolactone in patients with atrial fibrillation. And basically what they did is they took 250 patients with HFpEF and atrial fib, randomized them to spironolactone and placebo, and they did not find a significant difference on CPET testing with respect to maximal oxygen consumption or the distance walked in the 6-minute walk test. However, there was a numerical but not statistically significant reduction in hospitalizations in the spironolactone group, 15 versus 23%. And then finally, just to touch a bit on finerenone. So in patients with type 2 diabetes and chronic kidney disease, regardless of their ejection fraction, finerenone was shown to reduce both AFib and heart failure hospitalization. And we're all aware of the Fine Arts Heart Failure study, which showed clinical benefits of finerenone in our HFpEF patients with a reduction in the composite of CV death and heart failure events. And overall total heart failure events were decreased by 18% in this population, as well as quality of life improvements and NYHA status improvements. Now going on to our SGLT2 inhibitors. So we know that these reduce heart failure hospitalization and mortality in patients with HFrEF, MEF, and PEF, regardless of whether the patient has diabetes at baseline. The precise mechanism of the benefit of SGLT2s in heart failure is not known, but it's likely multimodal. So the natriuretic effects cause a reduction in intravascular volume and blood pressure. This reduces preload and afterload, and then decreases reflex sympathetic hyperactivity. There's an augmentation of the myocardial energy supply by increasing available ketones, and ketones are a more effective energy source for the myocardium itself. It's also thought that SGLT2 inhibitors can increase the levels of EPO and hemoglobin, which can improve myocardial oxygen supply. They can inhibit the myocardial sodium hydrogen exchanger, which can improve mitochondrial function and reduce oxidative stress and arrhythmias, and then can decrease sympathetic while increasing parasympathetic activity. Interestingly, there was also some studies that looked at epicardial adipose tissue and found that increased thickness of epicardial fat was associated with increased incidence and severity of atrial fibrillation. And one study taking diabetic patients with known coronary artery disease and placing them on DAPA versus placebo actually showed that DAPA reduced epicardial adipose tissue volumes. So one of the trials by Zelniker et al. In Circulation 2020 looked at this secondary analysis of the declared TIMI 58 trial, and they wanted to look at the efficacy and safety of DAPA versus placebo in 17,000 patients with type 2 diabetes and another risk factors, so atherosclerotic cardiovascular disease or known coronary artery disease. And they looked at the effect of DAPA on the first and the total number of AFib or aflutter events in patients with and without AFib or flutter, and found that DAPA actually reduced AFib or flutter events by 19%. And this was consistent regardless of the presence or absence of atrial fib or flutter at baseline. A history of heart failure did not modify the reduction in AFib or aflutter events observed with dapagliflozin. The DAPA-HF trial looked at incident atrial fibrillation and found that it was not reduced in patients that were randomized to dapagliflozin. And the benefits of dapagliflozin in the primary outcome of CV death or heart failure hospitalization, all-cause mortality, or any quality of life endpoints was consistent among patients with and without atrial fibrillation at baseline. Similarly, Emperor Preserved that looked at patients with preserved EF on empagliflozin, they also found that this medication did not reduce frequency of incident atrial fibrillation in patients with HFpEF without a previous history of atrial fibrillation at study enrollment. But regardless of presence of AF at the time of enrollment, the empagliflozin was still beneficial in terms of the primary composite outcome. And then similar findings were also seen in analysis of the DELIVER trial. Moving on to one of our older medications, digoxin. So we know that digoxin inhibits sodium potassium ATPase of the myocardial cells. This then promotes activity of the sodium calcium exchanger, causing increased intracellular calcium and increased force of myocardial contraction. There's also some vagomimetic effects with slowing of the sinoatrial and AV conduction. And then this medication is useful for rate control in patients with atrial fibrillation by increasing vagal tone and leading to reduction in AV conduction. So the DIDGE trial is an important trial that looked at patients with heart failure and an EF under 45% in sinus rhythm, and patients were randomized that were randomized to digoxin had fewer hospitalizations but no reduction in mortality. And they found a similar finding in patients who had an EF above 45%. A post-hoc analysis of this study actually found that there was a mortality benefit in patients randomized to digoxin when their serum concentration levels were between 0.5 and 0.9 nanograms per milliliter. And even though atrial fibrillation was not a specified endpoint in the DIDGE trial, hospitalization for supraventricular arrhythmias was actually lower in the digoxin patients. The FIRM trial, there was also a post hoc analysis of this trial that basically looked at rate versus rhythm control. And the post hoc analysis used propensity matching, and they found that there was an increased risk of all-cause CV and arrhythmic mortality in patients that received digoxin. And this excess risk of all-cause mortality remained when limiting the analysis to only patients with heart failure. But this analysis was limited. So patients on AFFIRM were randomized to rate or rhythm control, but there was not a specific rate controlling agent that was recommended. It was a mix of medications. And patients on digoxin in the AFFIRM trial were encouraged to aim for a serum concentration of greater than 1 nanogram per milliliter, whereas we just mentioned that the post hoc analysis of the DIDGE trial suggested that the optimal dosing for benefit is between 0.5 and 0.9. An analysis of the Swedish Heart Failure Registry looked at the independent association between digoxin use and outcomes, so a composite of all-cause mortality and heart failure hospitalization in a one-to-one propensity score matched population. It was a big trial, over 42,000 patients with heart failure and reduced ejection fraction. About 16% received digoxin, 29% in the atrial fibrillation group, and 2.8% in the non-AFib group. And they found that patients with AFib and digoxin had lower risk of all-cause death and heart failure hospitalization versus those who were on digoxin with no atrial fib actually had worse outcomes, increased morbidity and mortality. There's 2 ongoing clinical trials that are evaluating the efficacy of digoxin in heart failure patients while targeting specific and lower serum digoxin concentrations. It's the DIGIT-HF trial and the DECISION trial, and their results are expected to be out later this year. Ivabradine. So ivabradine is our selective inhibitor of hyperpolarization activated cyclic nucleotide gated channels that produce the IF or funny current. So there's no activity of this medication against other cardiac receptors or channels. So it imparts only a negative chronotropic effect that has been shown in several studies. But it was previously thought that these gated channels were present only in the sinoatrial node, but other studies have actually showed that they can also be present in other cardiac tissues, including the AV node. And one small trial that randomized patients with uncontrolled permanent atrial fibrillation, despite being on a concomitant beta blocker or calcium channel blocker, they randomized them to ivabradine or digoxin, and they found that ivabradine decreased mean daytime heart rate by about 11%, but this was less effective than digoxin. The SHIFT trial, which we all know very well, looked at our patients with heart failure and reduced ejection fraction under 35% who were on maximum dose of beta blocker with a heart rate and sinus rhythm above 70 beats per minute. And patients who had atrial fibrillation were excluded. And the ivabradine group, as we know, had a reduction in composite outcome of heart failure hospitalizations or CV deaths. Interestingly, the ivabradine group were more likely to develop atrial fib or atrial flutter during the study period, so 9% versus 8%. A meta-analysis of 40,000 people found that ivabradine was associated actually with a 15% increased risk of atrial fibrillation. And the hypothesis around this is that ivabradine affects the IF channels in the pulmonary veins, which is a very important structural substrate for atrial fib initiation and maintenance. And provides a potential mechanism for this finding. There was another heart failure with preserved ejection fraction trial called Edify, and they used ivabradine in patients with an EF above 45% and found that the incidence of atrial fib was not increased among patients assigned to the study drug. But this trial was very small, about 180 patients, and it was underpowered for that endpoint. And although patients with atrial fib were excluded from clinical trials evaluating ivabradine in heart failure populations because of a presumed lack of benefit, there are some studies that have revealed that ivabradine has heart rate lowering effects in atrial fibrillation. And whether the benefits of ivabradine in terms of hospitalizations and mortality are present among patients with pre-existing persistent AF who otherwise fit the shift enrollment criteria is still unknown and may be worth looking into. So I'll go through some of the less commonly used medications now. So hydralazine and nitrates, we know this combination therapy is effective in our African American patients with HFrEF, resulting in significant improvements in composite endpoint of all-cause death, quality of life, and heart failure hospitalization in the AHF trial. And there was consistent benefit of these medications in various subgroups of patients, including those who or did not have atrial fib at time of the study enrollment. Vericiguat is another less commonly used medication. So this one is an oral soluble guanylate cyclase stimulator, and the major trial for this med was the Victoria trial. And here, patients with an EF under 45% were randomized to either vericiguat or placebo on a background of other guideline-directed medical therapies. And the vericiguat group had lower incidence of composite of CV death and first hospitalization for heart failure. A post hoc analysis of the Victoria trial showed that treatment with vericiguat did not reduce incident atrial fibrillation compared with placebo. However, the beneficial effects of vericiguat, similarly to most of our other meds, persisted regardless of whether the patients had atrial fib at baseline. Another interesting medication, omecamtiv mecarbil, OM, is a cardiac contractility modulator, and this basically selectively binds to cardiac myosin, increasing myosin heads that are available for interaction with actin. The major trial that presented this medication was the Galactic-HF trial, and they showed that OM resulted in less incidence of a first heart failure event or CV death. And there was no significant difference in all-cause mortality or quality of life in patients with heart failure and reduced ejection fraction. Interestingly, they wanted to see the impact of baseline atrial fibrillation on the efficacy of this medication in patients with HFrEF. And they found that if they took patients with atrial fibrillation, digoxin, and OM, these patients had a worse outcome in terms of the primary composite outcome compared to those who were in sinus rhythm on digoxin and OM and had a benefit. And there is no, they don't really know why this difference in terms of AF versus sinus rhythm led to harm in the atrial fib group taking digoxin. But either way, this medication was also not approved by the US FDA. The GLP-1 receptor agonist, another popular medication these days. So the STEP-HFpEF trial looked at patients who had preserved EF and randomized them to semaglutide. They found that these patients had improved 6-minute walk distance and improved quality of life compared to the patients on placebo. And in this trial, more than 50% of the patients had atrial fibrillation at baseline. And they found that the semaglutide group actually had lower rate of serious events related to atrial fibrillation. In contrast, when looking at liraglutide, this medication failed to improve clinical stability among patients with HFrEF and a recent heart failure hospitalization, and it was found to have increased serious cardiac events in stable outpatients with HFrEF. Also of note is that some studies have shown that GLP-1 receptor agonists can be associated with increase in heart rate. So whether use of these agents may incite new atrial fibrillation is a topic of uncertainty. One meta-analysis looking at the CV safety of albiglutide found that patients had increased risk of atrial fibrillation. But again, there's conflicting evidence because a subsequent meta-analysis looking at this medication did not find increased risk of atrial fibrillation. And then finally, quickly in the last part of the talk, we'll talk about rhythm control as a new form of GDMT. And we know that rhythm control can decrease morbidity and mortality in patients with atrial fibrillation. And this benefit extends to those who also have heart failure. So a secondary analysis of the Cabana trial, where we had a mix of ejection fractions, predominantly patients with preserved ejection fraction, were randomized to catheter ablation. And there was a 36% decrease in the primary composite endpoint of death, stroke, bleeding, or cardiac arrest, and a 43% relative risk reduction in all-cause mortality. Similar findings were shown in the Castle AF trial. And then there is also the Castle heart transplant trial. So here, catheter ablation was considered for patients with end-stage heart failure who were eligible for heart transplant. And they found that the patients who were randomized to the ablation group had significant reduction in composite endpoint of death from any cause, implantation of MCS, such as a left ventricular assist device, or need for an urgent heart transplant. But rhythm control by medications is also shown to be beneficial. So a secondary analysis of the East AFNet trial showed that patients with signs and symptoms of heart failure, regardless of their ejection fraction, who were randomized to early rhythm control had a significantly lower risk of death from cardiovascular causes, stroke, and hospitalization or ACS. And most of these patients were given either amiodarone or flecainide, about a third and a third. Also, many arrhythmic agents it's important to realize that many of these antiarrhythmic agents are contraindicated in our heart failure patients because there's underlying structural heart disease, CAD, and elevated NYHA class. So this often leaves amiodarone as their only choice. And in one randomized trial of patients with HFrEF and AFib who are randomized to ablation or amiodarone, patients who got ablation had greater freedom from atrial fib, lower rate of unplanned hospitalizations, and decreased mortality. So it's not really well understood why rhythm control exerts such a benefit in heart failure. So some hypotheses is that, as we mentioned earlier, beta blockers may not have the same benefit among patients with HFrEF and atrial fibrillation. And one possibility is that this rhythm control strategy maintains the patient's normal sinus rhythm. Therefore, beta blockers work better and restore the morbidity and mortality lowering benefits of this medication class. Similarly, we know that mortality lowering benefits of CRT devices have been shown to be attenuated in patients with atrial fibrillation, giving another hypothesis for why rhythm control may improve outcomes. And then finally, one study looking at patients with permanent atrial fibrillation and concomitant heart failure, regardless of EF, with at least one hospitalization, and underwent AV nodal ablation and CRT implantation, found that there was improvement in quality of life, reduction of heart failure hospitalizations, mortality, and compared with people who are on pharmacological rate control. So, to summarize in the last few minutes, atrial fibrillation is common among patients with heart failure and is associated with worsening outcomes. GDMT maintains its morbidity and mortality reducing benefits regardless of atrial fibrillation status in heart failure and reduced ejection fraction. However, the data is a bit conflicting with respect to the beta blocker subgroup. Medical therapies for mid-range and preserved ejection fraction maintain their beneficial effects in patients with and without atrial fib. And rhythm control and catheter ablation for AFib improves outcomes in our patients with reduced EF. Some preliminary studies suggest improvements for patients with mid-range and preserved EF who undergo atrial fibrillation, though they may have increased AF recurrence and need for repeated ablation among those with HFpEF. references, and that's it. I'm happy to answer any questions.